Good morning and welcome to another webinar presentation hosted by the Southwest Ontario Regional Base Hospital Program. My name is John Duran. I'm the Interim Education Coordinator here, and today's topic will be ethics in EMS. We've had a change in the presenters. Unfortunately, Dr. Matt Davis will not be able to join us today. And for this reason, if there are any questions that come up that should be answered by Dr. Davis, I ask that you email those questions to me rather than ask it during the presentation. The two presenters that are here with me today, Dwayne Cotell, who is your pre-hospital care specialist for the London area, and Jeff Conway, who is an ACP and also a criminal litigator. So if you do need to ask a question, or if you have a question, there's two ways to do that. If you look at your control panel, you see a little hand. You can put your hand up, and then at the end of the presentation, if you have voice capability, I will simply unmute you and you can ask your question. Or the other way to do it is also in your control panel, you see a questions box, and you can simply type in a question for us, and like I said, we'll try to address as the best that we can. This is a little bit of a different type of webinar, and you know, there aren't necessarily right or wrong answers or direct answers. It's more of a discussion. It's more of a let's think about things. And I think that's all I had. So I'm going to turn it over to Jeff and Dwayne. Good morning, gentlemen.
Well, good morning, everybody. Yeah, it's Dwayne here, one of the regional paramedic educators at Advanced Care Paramedic, and joining us today, if you don't know him, Jeff Conway, Advanced Care Paramedic out of Middlesex, London, as well as a practicing criminal litigator. So the topic we're looking at, ethics in EMS, it's one of those topics and that's come up, and people wanted to discuss this and talk about decision making, that sort of thing, and sort of, you know, it's not so more of you know, defining the law. It's more of just making us aware of like decisions and, you know, how we should be making them, just keeping us on a path that's good for everybody, because that affects the public as a whole. So Jeff, do you have anything to comment on that?
No, good morning. Dwayne's correct. I practice civil and criminal litigation in London. Done so for our 7th year of practice. Just from the beginning, I'm not offering any opinions or legal advice. We're here to provide information and generate discussion. And also my information, I do not represent London Health Sciences in any capacity, and nor am I here to elicit any sort of advertising or marketing for myself. So that has to be clarified in the beginning. So good morning.
Perfect. Okay, so what we're going to be looking at today, the objectives of today's webinar, we're going to define ethics, morals, and ethical dilemmas. We're going to do a quick review of legal and ethical accountability in EMS and what that all exactly means. We're going to look at some common things that will happen for us on scene, some common ethical dilemmas. We're gonna look at some different cases, or examples rather, and just kind of generate some discussion. We're going to review some actual cases through polling questions of possible ethical dilemmas. And we're going to look at the various legal documents and acts in EMS in Ontario, as well as look at some ways of maybe trying to dissolve or like solutions to these ethical dilemmas. So when we look at some common ethical dilemmas we encounter during our work as paramedics in the EMS system, you know, some examples, you know, Jeff, what would you think are some examples that would, you know?
Some things that we've discussed in advance and that come to light right now. Terminally ill patients that are unconscious. we'll get into this in a bit more detail a bit later on. Say you've got a person who's been terminally ill, unconscious, say for a couple of days, and they're going to pass away at home. That's the family's wish. They've panicked. They've called 911. EMS shows up. They don't want the patient taken. What do you do? I mean, you've got probably an obligation to take a person who meets the criteria for medical care. However, you've got a dilemma. Most might decide the right thing to happen is for the patient to stay at home with their family, to die. You're not going to make their condition any worse. So that's one that we talked about. There's not a condition where there's not a valid DNR form on a person where you truly believe, and the case is that the person, that the DNR wishes were legitimate, but you don't have the documentation or the paperwork. The family wants nothing done. So those are a couple of questions.
Those are a couple things we'll get into there. So we're going to start off our webinar essentially with a poll question for everyone. And so the poll question is that a higher priority call comes in while you're at a residence to pick up a patient for a routine transfer, code 1 scheduled x-ray. So if you are close to the call, do you let dispatch know you're able to respond? So we're going to bring up your selections here. So the poll is
open.
It is open. So it's either going to be yes or no, and we'll give you a few seconds to kind of make your decisions, and then we'll close out the poll here, and then we'll see what everyone has to say, and John will relay that information to us.
Okay. All right. So 92% said yes, and 8% said no.
Okay. So great. That's excellent. And I'm going to ask Jeff to kind of talk about this, like. What is our standpoint? What is our position? Jeff, can you expand on, should we be making the effort to let them know?
I think, and there is, and once again, you're going to have to make that decision based on your experience, your local policies, your understanding of the Ambulance Act, and any other governing rules that you're bound by. You may hear people in the field say, it's not my responsibility, it's dispatch's responsibility to let me know where to go. What happens, maybe at a coroner's inquest when you have a duty to listen for your call number when you're on the radio, trying to explain that to a family of a child who's choking down the street. How much effort do you put into monitoring your radio? I mean, there's a gray area here. These are questions you have to be comfortable with answering yourselves on the fly.
I think that sounds fair. Like, I mean, we've always been taught that, dispatch is in control of the vehicle movement, that sort of thing. And, it really comes down to, it's like you said, it's very gray. It's a very gray area. But good. I think that's helped. So we'll just kind of move on here. So when we start getting into ethical, ethics, morals, and ethical dilemmas, so we'll look at the definitions here. So when we look at ethics, ethics is defined as the field relating to right and wrong, a duty and obligation, principles and values, as well as character. When we look at the definition of morals, that's social standards or customs, or dealing with what is right and wrong in a practical sense. And then where it all ties together for us is the ethical dilemma. So it is defined as a complex situation that often involves an apparent mental conflict between moral interpretives in which to obey one will result in transgressing the other person. So we can start looking at an ethical dilemma. Some of these examples, like culture beliefs. One is that, removal of faith-based garments in order to do an assessment because the patient is involved in a huge traumatic incident. You need to expose certain areas. And what do you do? What do you do when that is necessary? Do you do that? Do you not do that? Jeff, can you expand on what do you think about for that sort of thing, for performing our job to remove this clothing and that sort of thing? What would you think?
We have a duty to treat patients, to provide care to patients. We have a duty to the patient we may have sensitivity to their family, but at the end of the day, the duty is to take care of the patient. Suppose you have a semi-conscious or unconscious person and has faith-based garments on, and you have another family member, a husband, that may or may not want you to do what you need to do. I'm sure we're all very familiar with our resources, but maybe you don't have a police officer on scene. I think at the end of the day, most people would choose to perform any critical interventions that need to be done. But when you get into the gray areas, such as whether you need to do a 12 lead and while respecting the patient's privacy, how far do we push it? How far do you explain to the husband or to the patient, if it's a female, that these are very important? Are we becoming ethically lazy and taking advantage of an excuse, maybe not to do a 12 lead or do a little bit of extra work? How far do you push it? How informed and how important is it that you inform the patient even more and push it just a little bit further versus jeopardizing not performing a critical intervention, which could determine where you transport this patient, such as in the case of a STEMI.
Excellent. Another kind of dilemma is that, you have like a split crew. One person is IV certified, one medic is IV certified, one is not. And you happen to be on a call where there's been some type of a sexual assault to a female patient. They're hypotensive. The partner is a female medic that is not IV certified. However, you are IV certified. Like, the patient doesn't want the male in the back. How do you deal with this? We're going to be talking about these today. We're going to be going over those type of discussions and approaches to help guide us on our day-to-day work in these environments. So, which leads us to our next poll question. So, and it's actually what we just stated. So, you're working in a split crew configuration. So, it's a male ACP and a female PCP. A female patient has been sexually assaulted, is hypotensive, requiring intravenous access and a fluid bolus. So your partner, who is a female PCP, is not IV certified, and the patient does not want the male in the back attending. So what do you do? So we're going to open up the poll question here. So there's 4 choices: either A, have the female partner attend; B, just push your partner out of the way and attend on the call; C, call a supervisor to attend on the call and for some guidance; or D, discuss with the patient regarding their condition and outcomes and the need for this intervention. So we're going to leave the poll open for a few seconds here, and you take your time and ponder on that, and then we'll close it out here in a couple seconds.
Yeah.
And we'll see how we're doing.
And option D goes on. It looks like there's another option, but it's just we couldn't fit it all into the same line. So it's like there's actually only 4 choices: A, B, C, and D. All right, so we're going to close that up, and 100% of people said discuss with patient regarding their condition and outcomes and the need for this intervention.
Excellent. So that's kind of the answer we were trying to lean towards or go with, and I think that's, most of us have been trained that way, and that's a good way to approach the patient, and provide complete transparency and clarity for the patient. Jeff, if you want to weigh in on that decision-making process, do you feel that that's a good way to?
Absolutely. I mean, by telling the patient and maybe using different language or more, be a little bit more assertive in how you explain the situation. Obviously, if it's a situation where you've got time to sit and explain, it may not be immediately critical. However, there's still interventions that can be performed in the field that could be beneficial or are likely to be beneficial, and also our obligations to perform under our protocols and under what's required in the Ambulance Act. If you get to the point where the patient is still strongly opposed to the situation, you may waste more time negotiating than you would just to transport with the PCP partner. I believe if they ultimately refuse, ask yourself, what's going to be best for the patient time-wise. You may be at the hospital before you get them to agree to let that person be alone with them in the back.
Exactly. Yeah. They're very gray areas, and I think if we just use like just be very direct and give all the explanations without delaying transporting that patient to a higher level of care.
And you may anticipate this earlier on in the call. Perhaps have one person consider calling a duty manager and get some help, or patch in.
Yeah, absolutely. Perfect. So, kind of moving on here. So, when we get into our ethics, when we look at ethics, it can be broken down to professional, legal, and moral accountability. So, professional accountability, it confirms to standards based on a certification level. What that means is that we need to practice within our skill level, not jumping up or out of our skill set. So an example of that would be if a patient needs a needle crike and you're a primary care paramedic, well, you're not certified to perform needle crike. So yeah, don't do that. That usually doesn't work out well. And this holds true for ACT, just building on this crike thing, is that if you're not certified, some services choose not to utilize certain directives, and that's fine. That's completely fair. So if you are an ACP, even though you've been trained in it and you practiced it, but you're not certified in it through your service you're working at, do not utilize that particular skill set. The next point is accountability to the patient, medical director, EMS service, and the public. So we do have an accountability to perform care to the skill level we're certified in. If the patient meets the criteria for administering a medication or doing a procedure, then yes, absolutely do that. One of the examples of this is that, well, I have a patient with chest pain and I'm only 2 minutes from the hospital, so I'm not going to bother giving nitroglycerin. And, that starts to come into play of there was a duty to act and you breached that duty. Not only does it impact the patient in a negative way, but it also will affect the medical director, the service, and the public at large. So commitment to patient care, continuing education, skill proficiency, and certification. So we do have commitments to adhering to certain standards for our patients, maintaining our certification through continuing education and skill proficiency. And as a result, in Ontario, paramedics we're all required to complete annual recertifications. Primary care paramedics as well as advanced care paramedics do have mandatory service type of requirements, as well as advanced care paramedics have to attain a total of 24 continuing education hours or points. And then the last point on professional accountability is that we're governed by law at a certification level. Again, it comes back to practicing within our scope of practice and not going beyond that. There are situations where we may need to supplement our care with procedures that are not listed in the medical directives, or we have to kind of go outside of that. An example of this would be like a repeat dose of epinephrine for a pre-arrest anaphylaxis patient. So the scenario is, you're only allowed to give one dose, but you've given that dose of epinephrine, you've given the Benadryl to the patient, you've given them Ventolin because they're wheezing. If you're IV certified, you're moving fluid into them, and nothing's changing. So you think, okay, well, the patients, they're in trouble, so you patch in, and the doctor allows you to do a repeat of the drug, and that's fair, and we have discussed that. So question is, what happens if the patch fails? Okay, well, we are protected because when you actually look in your directive books under Southwest Ontario Regional-Based Hospital Program, page 8 does say for both PCP and ACP, and it's dealing with patching. So if the patient is in a life-threatening condition and the directive would otherwise apply, the paramedic is qualified to do so, and all reasonable attempts have been made to contact the base hospital physician for this order. And remember, reasonable is defined as 1. Okay, so if they're pre-arrest, they're dying in front of you, and you've tried and the call has failed, just do the procedure, go ahead and do it, and keep trying to patch through to let that base hospital physician know what you have done. So when we talk about professional accountability, we do have some wiggle room with our procedures. Yes, we're practicing at our skill level. It's just an addition to what needs to be done. So as we move forward here, we're going to get into the legal aspects and legal accountabilities. So I'm just going to bring these up so we can look at them all as a whole. So some of the legal accountabilities are through the patient care. An assumption of legal accountability is set. So what this means is we do have a responsibility to treat our patients. Patients are to receive a standard of care that reflects not only our medical directives as a whole, but also the basic life support patient care standards. Legal issues do often entwine with ethical issues, and we do have a duty to act, and we must do what's expected of us. There are acts and legislation and laws in place to protect us, the service, the public, and the medical director as a whole. So if we follow those guidelines, generally it's a good fit. Now I'm going to have Jeff comment on the next heading with ethics is not synonymous with law. Jeff, if you'd like to speak to that.
We've already gone over a couple of examples, so I won't go through them all over again. However, an example, a patient at home. Our duty compels us to act and treat the patient, transport the patient that's going to die at home. That doesn't ethically or morally make sense to a lot of people. So that's just an example of the two not being the same, ethics versus legal obligations.
Okay, and there are we'll try to abide by the law when ethical conflicts occur. And Jeff, do you have anything to say about that as far as the criminal code and that sort of thing? Negligence?
Well, under the criminal code, criminal negligence, it's a criminal offense. And if you look at the slide,
then we'll move forward to the next slide.
Self-explanatory. I'm not going to read through it, but it's about omitting to do something or doing something that can show wanton or reckless disregard for the lives or safety of other persons. So you can have a duty to act as a paramedic. If you don't, you could end up in a criminal negligence situation. Generally speaking, if you're doing your job, making a good effort to do your job, and you have well-founded reasons, it's going to be very difficult to get in trouble under this section.
Excellent, yes. And that's, there's a lot of like, what do I do? What should I be doing? Like, how far do we go? And like Jeff said, if we do a good job, and as long as we perform to our standard of care, and we have a duty to act, and we make every effort and document, then we're probably safe, right?
And an example I'd written down, driving really quickly, perhaps even somebody, everybody's probably exceeded the speed limit. If you were to roll an ambulance by driving in a crazy fashion, you could end up with a criminal negligence, or criminal negligence causing death charge. Or dangerous driving is very related to criminal negligence as well, especially where death is involved, versus careless driving, which is non-criminal, where you're not paying due care and attention. So there's a lot higher standard to be convicted under a criminal offense.
Great. Excellent. Good. It's nice to have that, what that means and define the definitions. So we're going to go, our next is getting into moral accountabilities. And I'm going to bring these up so that way they're all up on the screen. So morals refers to personal ethics. When we start getting into personal and societal values and beliefs, they do play a role essentially in our decision-making process. It's the human factors that gets slid into this. The personal ethics, they may shape how a person resolves conflict. Absolutely, everybody has a kind of a different path. I think we want to get to one common area, but it's the way we get there may be a little different. Emotion may not be a reliable determinant for making a decision. Yeah, so like, is it appropriate to allow our emotions to affect our decisions based on what we have in place to protect us, legislation, acts, directives, that sort of thing. And remember, decisions, that's, they should not be solely based on the opinions of others. Well, I mean, there are documents in place to protect us. That being said, that's with your partner, I've always been an advocate, I think it's good to be an advocate of, like, if you're not sure, ask your partner and say, hey, like, I'm not getting this, like, are we missing something, and bounce it off your partner. And remember, once the question is answered, generally it does become a guideline. And this is more along the lines of where medical directives come into play and some of the legislation. And we do have so many documents that governs what we do. And but these are set in place to protect us in the long run, and allows us to do our job with some form of autonomy. So moving forward, we're going to look at a few different things here. So we're going to be facing some common dilemmas. We do have dilemmas in the EMS. Okay, we're going to kind of go through these. There is a lot of information here, so just bear with us. So paramedics, we are going to face ethical dilemmas in the course of our career. That's inevitable. That is going to happen. Most of these dilemmas deal with the patient's right to self-determination. So, what the patient wants is something completely different than what we should be doing. There's many different examples for that. DNR, patient doesn't want, the family doesn't want somebody resuscitated. There's no DNR confirmation form, that sort of thing. So some of these dilemmas are dealing with paramedics to provide care. With that, some may choose to forego treatment because, well, I'm 2 minutes from the emerge and I just decided to transport. Well, that's may not necessarily be the choice I would make, and I think we have to look at the bigger picture. Autonomy and ladder benefits. So what this means is that it gives us the ability to practice freely and understand what needs to be done, and then utilizing what is in the patient's best interest in that particular medic's opinion, so they get the greatest benefit. And remember that we do have directives and standards that provide a wide safety net for us to provide pre-hospital medicine, pre-hospital care. Some of the questions we want to think about is what is in the best interest of the patient, destination policies, what are the patient's rights? Example, that's a DNR confirmation form. Does the patient meet the aided capacity? And that's through our ACR aided capacity section. And what is the paramedic's professional, legal, and moral accountability? So just questions to keep in the back of your head. So we're going to go to another poll question, or case question here, and we're going to take a look at this. And so the case is you're sent code 4 for a possible VSA patient. You arrive at the residence, find the fire department performing CPR, and they have their defibrillator attached. They inform you they've been performing CPR for 6 minutes and have had 2 shocks delivered. You attach the defibrillator and continue with the resusc efforts. The patient's spouse tells you that he didn't want any heroics done and to stop resuscitation. When you question the spouse, a wife in this case, about a DNR confirmation form, she produces a living will. So,
okay, so let's put up the poll question.
Yeah. So the 4 choices, the first one is stop the resuscitation as per the wife's request, continue with the resusc efforts and transport the patient, perform a base hospital patch for advice, or call for a supervisor on scene to assist. So we'll just leave that open for a couple seconds, and then you make your decision, and then we'll talk about it.
Okay. All right, so let's close that one up, and we've got number 3, 75%, 2 is 20%, 4 is 5%, and nobody picked number 1 option.
Okay, so yes, now I'm just going to go ahead to the next slide here. Okay, sorry, just bear with me, technical difficulties. So when we look at the BLS manual, it does state that the DNR policy, the policy doesn't apply to orders or directions given by a family member outside of the policy, nor does it cover other types of do not resuscitate situations that are not within the scope of the practice. Jeff, if you want to comment on that, please.
So if there's a living will that perhaps in the will sets out an advance directive that the person doesn't want to be resuscitated, if you're an ACP, you have the option of patching in, and I don't know of many cases where you wouldn't be granted by the physician, but it's still his choice. It's tougher if you don't have that option. You have a duty to transport, and it's just one of those situations that due to nothing non-malicious, but planning that wasn't really planned to the way it should have been or could have been, the person's probably going to end up leaving their home in the ambulance.
Yeah. And just keep in mind that these case studies, again, there's no right or wrong answer. Most of you have chosen performing a base hospital patch, and you would not be wrong there. Absolutely, anytime there's any kind of extenuating circumstances, it's always good policy to phone a base hospital physician for advice.
Excellent. Excellent. So we're going to move on. We're going to throw another case up here for us, case number 2. So you're saying code 4 to a resident for a patient experiencing chest pain. You arrive to find a female patient in obvious distress, and you have a full sample history, which includes an MI with previous nitroglycerin use. You complete your assessment and start to treat your patient under the cardiac ischemia medical directive. You do a 12 lead, and she is STEMI negative. When you're preparing to extricate the patient from the house, you inform her you'll be taking her to the closest emerge. The patient tells you that she wishes to be transported to the hospital where she had her PCI done with her last STEMI, which is about another 20 kilometers away. So what do you do? So I'll bring up 4 of the choices here, okay, and then we're gonna open the poll. So are you gonna transport to the PCI center as she's requested? Are you gonna transport the patient to the closest emerge? Are you going to have a conversation with the patient and explain all the risks involved by going that extra distance? Or are you going to perform a base hospital patch? So I believe the poll is open. So if you'd like to go ahead and vote.
Yeah, it is. Okay. So I'm going to keep it open for a few more seconds, get more people voting, hopefully.
Perfect.
All right. Okay, so let's close it up. And okay, so number 1 option, nobody picked that. Number 2 option was 50% of you. Number 3 option was 39%. And number 4 option was 11%.
Okay, great. Excellent. So when we look at what the BLS manual says, making a decision regarding transport, I'm going to bring all these up for everybody to see. So we do have a lot of options, okay, and a lot of options and different paths to go down. So dispatch maybe directing you there. If there's an attending physician and they speak to dispatch, if the coroner happens there, which is not the case, doing a base hospital patch, sure, absolutely. Midwife, but this doesn't really apply in this case, but that is an option as well. If there is a approved local transfer guidelines, so like bypass criteria that's in place, and then the patient, and this patient seems to be adamant with dispatch's approval. Jeff, do you want to expand on as far as transporting, if they're not wanting to go to the closest emerge and it's a condition that, correct hospital, appropriate facility?
I mean, as Dwayne had said, that it's going to be a judgment call to a certain degree, but your best bet might be to start driving toward the closest hospital, but patch in. And obviously, if the patient starts to deteriorate, that's going to make your decision easier. If the patient starts to improve, perhaps you give them some nitro and a chest pain call and alleviated some of the symptoms, and perhaps it might be justified. And that might be a factor that will be a factor that the base hospital physician will take into consideration.
Oh, perfect. Excellent. Okay, good. So we'll kind of move on. There's a lot of cases we're going over today, just more of a discussion thing today, so which is great. So this case here, you're sent code 3 for a patient who is unable to thrive. You arrive to find an elderly male patient has been short of breath and fever. The patient presents with poor hygiene. The home is in disrepair and complaining of weakness. The patient also presents hypotensive. You talk to the patient, you advise them of your treatment decision, and the patient states that, he just does not want to go to the hospital. So I'm going to bring up a few choices here. So what do? So do we transport the patient against their wishes? Do we have the patient sign a refusal of service and we just leave? Do we use whatever means necessary, convincing the patient for need of care and transport? Or do we perform a base hospital patch for advice? So the poll is open.
Okay, yep. And once again, we'll leave it open a little bit longer just to get more people in on the poll. Okay, and I think we'll close it up. So number one option, 6% of you picked that. Number two option, 0%. Nobody picked that. So the most popular in this case was number three. Use whatever means necessary to convince the patient for need of care. And number four was picked by 17% of you. So
excellent. So I'm just going to go forward a couple slides here, a slide or two, and we're going to look at what it says about doing the assessment and what our obligations are. And we know we do have to do a thorough assessment and take into consideration all the facts that we're presented with the patient. We know how to do our assessments. We've been trained to do that. And then we start getting into aid to capacity. Okay, the ACR documentation manual does state that the patient is presumed to have the capacity to refuse treatment and transport unless the paramedic has reasonable grounds to believe otherwise based on confused or delusional thinking, they're unable to make a settled choice, severe pain, anxiety, or fear, there's judgment impaired by alcohol or drugs, or other observations causing concern. So I think in the big picture, that the answer we selected, I believe, was number three. The majority of the people selected. I think that's a good path to go down, just for the simple fact of the patient is hemodynamically compromised. They're fevered. They're short of breath. They're living in maybe conditions that aren't conducive to a healthy environment. And those are reasons. Get on the phone with dispatch if you need assistance. Get your supervisor out, do a base hospital pack, have the police attend, and maybe they can help convince. Jeff, do you have any comments on that?
I mean, we have to keep in mind people who meet the capacity requirements have a right to make poor decisions about their health that we won't agree with. Consider other resources. If they're in a house that's very unsafe, perhaps police could be of assistance. Might have other options of having them removed. Police may not let them stay there, or a fire inspector. So,
yeah. And once again, just keep in mind, a number of you did pick number four option, perform a base hospital patch for advice. You're not wrong there either. Like I said, these questions, they're not to be looked at as completely right and wrong, and that there is one option that we're really looking for. It's more to get you thinking about these situations that you encounter on a daily basis on the job.
We're dealing with the gray.
Yeah, exactly.
Yeah. So we're going to do another case here. I'll bring this up. So you're saying code 4 to a residence for an infant with possible burns. You arrive to find dad holding a 9-month-old little boy in his arms. The infant is screaming, and dad tells you he was boiling water and a pot tipped over and spilled onto both of the infant's feet. When you examine the child, you find that both feet have possibly second-degree burn blisters that cover them, the feet entirely. You also note a clear demarcation line just above the ankle on both sides. You dress the wounds according to the BLS standards and prepare to transport. The dad is very protective of his child and questions everything that you're doing. He wants to accompany the child in the back of the ambulance. And for some reason, you're suspecting this infant may be a victim of child abuse. So I'm going to bring up a few things. So what are we going to do here? So I'm going to bring up 4 choices. Okay. So the first one is you're going to confront the dad and threaten to boil his feet. I mean, that's you're going to transport the infant to the hospital and relay the story to the ER staff. You're going to notify the ER staff and Children's Aid Society, or you're going to question the dad more regarding the spilled pot. So the poll is open. So if you would like to go ahead and answer that, take a few seconds to answer that.
Okay, so we're going to leave it open a little bit longer. Okay. All right, so let's close it up. And nobody for 1, 27% for 2, 68% for 3, and 5% for 4. Now, is this something that you're gonna address, Jeff?
I would just be. It could be other reasons. I mean, if somebody's called 911, maybe dad has called 911. Maybe you feel dad's being evasive. Is dad maybe protecting mom, or is he upset that the babysitter or somebody just left the child in care with caused this accident? So just be careful of being suspicious. There could be explanations. Here you have somebody who's called 911 might be worried that he could get in trouble for maybe making a mistake, but it doesn't necessarily mean that he's done anything criminal.
Exactly. And the BLS does state, we make no accusations, comments, or about suspicions. We transport the child in all cases, and if we are really suspecting this, then we do have an obligation to report that to the emerge and to children's aid. That is right out of the BLS manual. Okay, so it is our legal obligation, and as Jeff said, though, don't assume they're guilty right off the bat.
Right.
It could have been something very benign.
They may feel guilty for having made a mistake or had an accident. They could feel just as guilty and look just as suspicious, I guess, in that scene.
Excellent. Perfect. So there are, just getting into the different acts that we have, I'm going to bring them up and then I'll talk about them very briefly in regards to the stuff that governs us. So the Ambulance Act, we have that's been in place since basically the inception of EMS in Ontario, and it touches on all the aspects regarding operations, regulations, qualifications, definitions, licensure, that sort of thing. The Controlled Substances Act, and there are rules and guidelines regarding transportation, documentation, security, and reporting of medications, which are include but are not limited to opiates and benzodiazepines. The Coroner's Act, that is in place and addresses obligations of the coroner, rules and regulations surrounding the disposition of patient. It also addresses termination of resuscitation concerns. The Child Welfare Act is specific to children, and it addresses the specifics like abuse, neglect, assault, abandonment, those sort of things. The BLS Patient Care Standards Manual. So it's essentially our rule book for basic life support procedures of all patients we encounter. It is the bare minimum standard that we have to adhere to. We also have our Advanced Life Support Patient Care Standards Directives, and it's our Delegated Medical Acts Playbook, and it provides us with the parameters, the accepted application of medication administration procedures, and specifics surrounding patching and patching or not patching for orders. The Criminal Code of Canada that applies to everyone in this country, and it designates, defines, and provides information on what is legally acceptable. And then the Highway Traffic Act, and what this kind of deals with, essentially the rules for us holding our Class F license or above, so that way that is conditional for us to drive an ambulance. And remember that all these documents, acts, legislation, these are all in place to protect us, the patient, and the public and the medical directors at large. Jeff, do you have any comments on this?
Oh, those are really good points, Dwayne. I just wanted to say that. Thank you.
Okay.
Yeah, so that essentially wraps up our webinar.
Okay, and so what we normally do, well, what we've done anyway since I've been here, is at the end we leave everything open for about a minute to see if any questions come in for you specifically, Jeff. Like I said, if your question is related or is directed at a medical director, I would appreciate if you emailed me and I can forward that to Dr. Davis. So we've got a question coming in here now.
Can you see it?
Can you see that? Okay, so I think this goes back to one of the poll questions and one of the case questions. So there was a scenario. I'll read the question to everyone. So there was a scenario provided involving a wife presenting a living will to stop resuscitation of her husband. The majority stated that they would patch to a base hospital physician. Another option was to simply transport. One of the presenters said patching wouldn't be wrong. However, the patient has been shocked twice and does not have a valid DNR. The only legal document allowing us to stop resuscitation in the field. I feel patching is a clear infraction of what is clearly outlined in ACLS and BLS standard. Can you elaborate on what you feel is a correct response? So Jeff, from your point of view, please.
I know as an ACP, I mean, we have the option. Obviously, the standards speak to resuscitation. ACLS speaks to resuscitation. We have an added ability through our base hospital to patch in these situations. I've done it before during situations like that. Obviously, it's been shocked twice. That would normally be a patient that's transported. However, this isn't a normal situation. Now, I don't know if this is a PCP-based question or an ACP-based question. You might have a little more difficulty with as a PCP. However, I believe we've heard here, you're probably not going to be wrong in this case to patch. You can continue your resuscitation and get clearance from above, so to speak, through the base hospital doctor. So.
Right. Okay. Thank you, Jeff. Yeah, thank you for the question. And what I can do is I can actually forward this this question to Dr. Davis and see his take on it as well. I know we didn't quite answer your question, but like I said, with this topic, it's kind of hard, and we're not really dealing with black and white. We're certainly in the gray zone for this entire discussion. Are there any other questions? Okay, so we'll just wait another 30 seconds or so to see if any questions come up. And I don't see any hands. Okay, so it doesn't look like we have any more questions. So I would like to thank everyone for joining us for this early presentation. I know normally we do them a little bit later. And I would like to thank Dwayne, and I would like to thank Jeff for coming in and presenting this very interesting topic.
Thank you.
Have a great day.